Okay, you guys ready to get started? I apparently am. Until I get booted off the internet, it will be bad. Okay. So we're going to run through 2-slide presentations. First one we're going to talk about is pre-gestational problems. How's it going?
What are you?
I don't know how to work this dang. Oh, there we go. I just hit it. Okay, so gestational diabetes. I didn't put all the slides about diabetes. So women can come into pregnancy already diabetic. Okay, so we know that. They also can develop diabetes in pregnancy because the whole process of pregnancy creates carbohydrate metabolism problems. So we check these women during pregnancy for gestational diabetes. Now here are some of your risk factors for diabetes. So we have an increased insulin production related to the estrogen, progesterone, and tissue sensitivity. So we have an increased response by insulin. And then we can have, in our first trimester, problems with morning sickness, nausea, and vomiting. So we have a decreased appetite. And so we're usually fine during the first trimester. This is why they don't test us until about 24 weeks gestation for gestational diabetes, because usually in the early part of pregnancy we don't have an issue with, oh no. Usually we don't have an issue with blood sugars and stuff during the first part of pregnancy. However, in the second half of pregnancy, then we start developing a resistance to insulin and a decreased tolerance for glucose. Okay, so then we can start seeing higher blood sugars. Now, if we do have gestational diabetes or diabetes during pregnancy that is not controlled, when we get into our second trimester, we can really set ourselves up for some maternal issues. And here are these issues, okay? Now, for fetal risks, if we have unchecked diabetes of any sort, baby's going to start having a lot of problems. And if she is a diabetic before pregnancy, and if she has uncontrolled blood sugars before pregnancy, and then starts the pregnancy that way, this could be very detrimental to the baby. The baby could have severe congenital anomalies, and she may end up losing this pregnancy, okay? But if this pregnancy does continue, we can have problems with baby at delivery that we're going to need to deal with, okay? So we screen about 24 weeks, depending on the physician, and there's two protocols that the doctor can follow. A doctor can choose to follow the American Diabetic Association protocol or the ACOG, which is the College of Obstetrics and Gynecologists, okay? So the Diabetic Association, they'll have you test the A1C, and if it's equal than 6.5, she will probably be diagnosed with gestational diabetes. If her fasting glucose is greater than 126, or if on 2-hour plasma glucose where she drinks that sugary cola, if she tests greater than 200, then she's probably just going to be diagnosed with overt diabetes, not gestational. Okay, but anyways, they do the 2-hour glucola screening. They drink the 75-gram yummy syrup. And then they test her blood sugar at 1 and 2 hours. And if she falls in these parameters here, then she gets diagnosed with gestational diabetes.
Which is a more common test that doctors prefer?
Yeah, I think they more so go with the ACOG one actually. And this is the ACOG one. So they do a 50-hour, or they do a 50-gram glucola test. They test at 1 hour, and then they like to test again at 3 hours. And if she is greater than, what are their parameters? Oh, I don't know that I put, oops, shoot. I don't know how to go backwards.
I think 50 grams needs to be 120 or below.
Yeah. So I didn't put that slide on here. I'm sorry. So check that in your book. So this is the ACOG one. So it just depends on what your physician prefers, okay, which one he uses. Now, a lot of times, even if they are diagnosed with gestational diabetes, they will start out trying these women on diet controlled, okay? And she'll be checking her glucoses, fasting, AC, but they're really into a 2-hour postprandial, so 2 hours after a meal, they'll check her glucoses. But if she can't control her blood sugars with diet, then they will put her on an insulin, okay? And they typically do not do oral insulins, okay? However, you know, recent studies are suggesting that she could probably take glybride or metformin. But my experience here with these physicians is they just put them on insulin regimen, okay? And a lot of times they're referred to some sort of endocrinologist or something, someone else, if they have blood sugars that are, that they can't keep controlled, okay? They'll probably be hooked up with a diabetic, you know, outpatient diabetic educator. And so there's your, there's our little blurb on gestational diabetes. Anybody have any questions before we move on? Okay. What are we going to see with our baby after delivery with his blood sugars? They're going to drop. Why are they going to drop? Huh?
Because he's been used to mom's hyperglycemia and all that sugar, so that
right. So insulin doesn't cross the placenta. Baby makes their own insulin, and then when baby's delivered, baby doesn't have that large supply of sugars anymore. So baby will bottom out their blood sugars. Okay. So for any baby that's born to a diabetic mother, whether gestational or overt diabetes, or even just a large baby, we will do a 24-hour, watch their blood sugars for 24 hours, okay? So we'll test babies before feeds.
How often?
Just before feeds, so 2 to 3 hours.
Once you feed a good idea, so thinking here, if they give glyburide or metformin during pregnancy, the fetus isn't going to be producing as much because it does not pass the placenta. So is not
A small amount does pass the placenta.
Will it lower the risk of possible blood sugar?
Not after pregnancy, okay? So a small amount does cross the placenta, but not enough to make us feel comfortable with baby after delivery, okay? And they haven't really studied this with breast milk, but they're concerned about too much of it crossing in the breast milk for her to be on POs postpartum, so depending on if she's breastfeeding. Okay, so now we're going to move. Any more questions about that? Did you have a question?
No.
Okay. So now we're going to move on here to fetal assessment during pregnancy. One of the things that we can test for neurotube defects, my tongue isn't awake yet this morning, is we can do an alpha-fetoprotein test on mom, and depending on the presence of alpha-fetoprotein, we can suggest that maybe baby is at risk for a neurotube defect. And then we would move on to ultrasound. Ultrasound we can do in the first trimester. We can do it all throughout pregnancy. We can confirm gestational age. It's very accurate if done in the first trimester of pregnancy. Ultrasounds can be used to look at the placenta, look for bleeding, check for fetal anomalies. They use ultrasound for guidance during amniocentesis. So ultrasound is a very common thing we do for baby. However, if the physician does not have an ultrasound in his office, then he needs to write an order and send her to the hospital for ultrasound. And then someone needs to pay for that. Now most insurances will cover a first trimester ultrasound, and then they will cover ultrasound if there's a medical indication or an obstetrical indication to do the ultrasound. But if we're just doing ultrasounds just to take a look, see, they won't cover that. And so that will be up to the patient to cover. But if the physician has an ultrasound in the office and he can just throw it on there real quick during her prenatal exams, then that's great. So how often they do these is dependent on obstetrical need, mostly, okay? Now the fetal biophysical profile is an ultrasound and we do this to check fetal well-being. This is usually done, oops, sorry. A biophysical profile is usually done anywhere from 28 weeks to term, okay? We're checking fetal well-being. For whatever reason, we're concerned about baby. The biophysical profile is composed of a non-stress test, so that is done in either the clinic or in the hospital, in the labor unit. And then she goes down to ultrasound. They look at fetal breathing movements. They look at fetal movements, arm movements. They look at the amniotic fluid, and I'm missing one. Fetal movement, breathing movements, and tone, okay? Amniotic fluid and tone. So for each one of those parameters, baby will either get a score of 2 or 0. Okay, there's no 1, there's no half, it's either 2 or 0. So if baby has good breathing movements, good tone, good amniotic fluid, and good arm movements, baby will get a 2 for each one of those parameters. So that's a total of 8 points. Okay? And then we do the non-stress test, and if baby passes the non-stress test, baby gets another 2 points. So it's a total of 10 points. Now a lot of times we'll do the non-stress test in the hospital, and they'll fail the non-stress test. We'll call the physician, and he'll say send her for a biophysical profile. Okay? So she failed the non-stress test, so she gets a 0. And then she goes and has the ultrasound and gets scored for those other 4 parameters. And depending on what her score is, if she's anywhere between 8 and 10 on her score, then we say that we have a good baby and we can send her home, okay? If she scores 6 or below, she'll probably be admitted to the hospital on at least continuous surveillance, okay? But if she scores 4 or below, she's getting delivered. Okay, so if she scores a 6, she'll be admitted to the hospital on continuous surveillance, and hopefully, you know, we'll be watching baby that whole time, and we can keep her pregnant as long as we can. But if she gets a 4 or below on the biophysical profile, she will get delivered.
Points are bad.
Huh?
Points are bad.
Points are bad?
No, points are good.
Taking points off. Yeah, 8 to 10, she's good, but if she starts scoring lower, then that's not good. Okay? Did you, how did I screw you up?
Less than 4, she gets delivered.
Yeah, so we don't want her delivered if she's 32 weeks. But if her baby is sick enough and got a 4 on that test, then baby will be better off in the NICU than in utero.
It's time to get it out.
Right. Okay, so we do the non-stress test. The non-stress test, they're on the fetal monitor. Some of the OB doctor's offices have fetal monitors and can do the test in their office. Some do not, and we have to have them come to the hospital. We do the non-stress test now. We're looking for fetal movement, and then with that fetal movement, we're looking for accelerations in the heart rate. Accelerations are a positive sign of a well, healthy baby. Sick babies do not move and they do not accelerate their heart rate, okay? And then those accelerations, the criteria for that is that we need 2 movements, 2 accelerations in a 20-minute period. And those accelerations have to be 15 beats above the baseline for at least 15 seconds, okay? Now, if she's preterm, we will give that baby a little break and say 10 beats above the baseline for 10 seconds. But still, it has to be within 20 minutes. So if you have her on the monitor for 40 minutes and she has her first acceleration at 10:05 and doesn't have her next acceleration until 10:45, baby didn't pass the test. It has to be within 20 minutes, okay?
So if you failed that, then you go do a...
Then we probably go do the
biophysical
biophysical profile. We'll call the doc and say, baby failed.
And do you redo the non-stress test after that? It's a one-time deal?
Yeah. Well, I mean, for that day.
Okay.
Okay. So maybe baby scored an 8 after the biophysical profile, and doc said, okay, come back in a week, let's redo it. Okay, so we'll redo it next week. Some women, especially diabetics or women with hypertensive problems or women with cardiac problems or women who have a fetal growth problem, for whatever reason the doctor says, hey, I want you to have NSTs every week. Okay, so there's some gals that do that. Okay, now when we say we don't say, hey doc, she passed her NST. Okay, we say, hey doc, she had a reactive non-stress test. Reactive is a positive word, so she's positively not stressed, non-stressed, okay? That's if she passed the test. If she did not pass the test, then she's got a non-reactive, non-stress test, okay? All right, the other one is a contraction stress test. We don't do these very often. A contraction stress test means we have to get the woman to contract. Now, if she's 28 weeks, we don't really want her contracting, okay? But what we're trying to do is we're trying to see if baby's going to tolerate contractions. Maybe we want to induce this woman, and we have a questionable baby to begin with, so we're gonna just check and see if that baby's going to tolerate labor. So this woman has to be contracting. Now she can either be contracting spontaneously, which rarely happens when you want to do a test. She'll contract every other time, but when you're wanting to do this test, she won't. So we have to make her have contractions. And how do we make her have contractions? Pitocin. We give this gal Pitocin, okay? Or if we don't want to give Pitocin, we have her do a nipple stimulation test, where we have her roll her nipples, and then she'll stop, and then we'll have her roll her nipples. And so we're looking for 3 contractions in a 10-minute period. When we get 3 contractions in a 10-minute period that are 40 to 60 seconds in duration, then we stop the test. And then we look at the fetal heart rate with those contractions, okay? We might be able to get this test done in an hour. It might take us 4 hours to get this test done. So, oh shoot, I didn't mean to bring that in here. So where was I? Okay, so we look at the fetal heart rate during those contractions. If the baby is having late decelerations or variable decelerations with those contractions, baby has failed the test. Now we call this, we term this opposite of what we termed the non-stress test. So if baby fails the test, baby had a positive contraction stress test. Baby was positively stressed with contractions, okay? If baby passed the test, we say baby had a negative contraction stress test. Baby was negative for stress during contractions, okay? So it can be a little confusing, but that's how you have to talk yourself through that. Oh, this this slide was supposed to go with the diabetes slide. Sorry, but they get a little mixed up there. But anyways, for delivery, women with diabetes or gestational diabetes, if they have a macrosomy baby, so what does that mean? They have a very large baby, okay? Her chances of delivering vaginally decrease as the size of the baby increases. So we've delivered babies at 36 weeks that were 10 pounds. Okay, that ain't coming out vaginally. And if we wait to 38 weeks, how big's that baby going to be? So a pound a week, you know? So we may end up doing an elective C-section for macrosomy, okay? But that's one of the reasons why we may be delivering her early, is because she has such a large baby. And if she does want to attempt a vaginal delivery, because she can refuse a C-section, we may have to deliver her early so we don't have such a massive baby, okay? But anyways, these are reasons why we would deliver a diabetic mother, okay? Wow, like the other one was just thrown in there, I guess. Okay, so during labor, we check blood sugars on mom every hour, okay? She's usually NPO when she's in labor. Some physicians will let her have clear liquids, popsicles, Jell-O, but she's pretty much NPO, so we may be running D5 solution on her, okay? But we do need to check her blood sugars hourly. And then she may be on an insulin drip during labor. Okay, we don't give sub-Q insulin during labor, we just put them on a drip. Okay. And then so if she's gestational, or even if she's diabetic, so any person who's going through some sort of sickness or trauma or stress, you know, their blood sugars can all of a sudden be elevated when they were normally under good control. Labor is a stressful environment, so after she delivers, her glucose levels may return to normal quite quickly. And we do encourage we encourage everybody to breastfeed, but anyways, there you go. Now, if we have a patient in our facility that's pregnant and we're not delivering her, or we don't want her to be in labor, then we check her blood sugars, fasting, AC, and 2-hour postprandial, and then a HS blood sugar. So for the gestational diabetic, again, postpartum, her glucose levels may return to normal quite quickly. They seldom need insulin. If they're elevated, then they can have orals, except if they're breastfeeding. Okay, oral hypoglycemics. But if she's breastfeeding, they don't want to give her orals, okay? So they'll recheck her in 6 weeks, and then they'll suggest to her that she is checked every 3 years, because if you develop gestational diabetes, you have an increased risk of developing overt diabetes. And you'll probably have gestational diabetes with each pregnancy.
Doesn't
Yeah.
it put the baby at increased risk for diabetes also?
Yes, childhood diabetes, onset, hypertension, heart disease. Okay, so we're going to talk about anemia, because anemia seems to be a really big issue with our population, at least here in Montana. So there's, 3 or 4 different kinds of anemias. The most common here is the iron deficiency anemia. Usually, hopefully, we can just, encourage her to eat a diet rich in iron, but that's probably not something that she's enjoys, so that's why she's probably anemic to begin with. So we will give her a supplement during pregnancy. Now, if she does have anemia, iron deficiency anemia, these are her problems during pregnancy, okay? So yeah, she is more tired, more susceptible to infection. She's got increased risk for eclampsia problems and postpartum hemorrhage. And then if she does have a postpartum hemorrhage, someone who's already anemic, then we might have some severe issues with her after delivery. Now for the baby fetus of a mother, so they can have low birth weight, prematurity, and death just because there's not the blood volume and gas exchange and nutrient exchange going through the placenta, so the baby's going to suffer, okay? Now, sickle cell anemia is, a recessive autosomal disease. It's kind of rare in this area. I'm trying to think in my 3 years of working here if I've ever had a patient with sickle cell disease. But anyways, so the red blood cells have the sickling shape, and so they don't oxygenate, or they don't carry oxygen very well. And so that kind of sets the mother up for the same problems as any type of anemia, except for addition of these things: jaundice in your mom, infarction, acute pain, okay? So when we have a gal with sickle cell, we do a lot of hydration. We will probably be running a lot of oxygen to help both mother and baby. And then she's on continuous monitoring during labor, or even if she's just admitted antepartum wise. So here's some more problems mom can develop with sickle cell. And here again are what we're going to do to treat mom. Now for the baby, preterm labor, prematurity, intrauterine growth. Pretty much the same with any of these anemias. Baby is not getting the blood volume through the placenta. Baby is not getting adequate oxygen, gas exchange through the placenta, or nutrients for that matter, okay? The other is folic acid deficiency. We put these women on a folic acid supplement in addition to their prenatal vitamins. We want to do this before pregnancy because baby has a huge risk of a neural tube. Baby has huge risk of neural tube defects, okay, with the folic acid deficiency. Anyways, we will suggest diet to her to increase her levels. She may need a blood transfusion during labor, and she is very susceptible to hemorrhage and she's already in a compromised state with her sickle cell, or I'm sorry, with folic acid deficiency, that the hemorrhage may put her in a very life-threatening, critical situation. Women with folic acid deficiency, their babies are at huge risk for neural tube defects. And we really do want to get these women, like this rarely happens. Does a woman come in and say to her physician, oh, I want to get pregnant, test my folic acid, now put me on a supplement, and then in 3 months I can get pregnant. Okay, so that rarely happens. Usually a folic acid deficiency on a healthy 20-year-old woman otherwise has not even been detected until they get pregnant. These babies are at huge risk. Okay, any questions with anemia? So basically the bottom line with pretty much any of your anemias is, so mom's already compromised with her oxygen carrying capacity, okay? So that means the placenta is going to be compromised. That means the baby's going to be compromised. So we want to get these people on supplements. And then when they're in labor, we've got to watch this baby closely, because this baby may already be IUGR, may already have some problems in utero, may not tolerate your labor. And then after delivery, okay, baby may have some anemic problems after delivery, but mom is at huge risk for a hemorrhage and her ability to, hi, you can come in, but so we plugged in with this cord to the internet in my computer and it wouldn't let us go. And now I'm logged on to the guest network, and let me just pause my recording, because I'm recording my lecture here.
Okay.
Okay. Huh.
I printed out both of them, but it's 69.
You guys have to go, don't leave yourself.
Okay, so let's talk about heart disease in your mom who is pregnant. Okay, so pregnancy, as you guys know, puts increased demands on the heart, just because of the increased blood volume, increased heart rate, increased cardiac output. Okay. Usually healthy moms tolerate this without any problems at all, but if they have any type of heart disease, they're going to have a hard time during their pregnancy, as you can probably imagine. Okay. Now here are some of the more common heart problems we can see on our moms: an atrial septal defect, a ventral septal defect, a patent ductus. So mom can have a patent ductus that she lived with all her life, right? Okay. Coarctation of the aorta and tetralogy of Fallot. That's the four-heart tetralogy of Fallot. Is to be diagnosed with that, you have those 4 different heart defects all at the same time. Okay. All right, here's some of the less common heart problems that we see. Eisenmenger's syndrome, okay? There's a shunt between 2 chambers, which increases the congestion and blood overflow in the lungs. So we have the reverse shunting, the right to left shunting. Pulmonary hypertension, an uncorrected coarctation, aortic stenosis, and Marfan syndrome. Now, so what does that mean? Okay, so depending on the heart defect, they may go through the pregnancy just fine, They may have a few symptoms. But if your mom is having problems cardiac-wise, then your baby's going to start having problems, okay? It increases the risks for baby. So she, for whatever control she needs, medications she's on for her heart problems, or just increased surveillance. So she will have her prenatal exams more often. She may start coming in at 28 weeks for a non-stress test for us to watch baby. And if mom is compromised in any way, shape, or form, she may end up getting delivered, okay? Rheumatic fever is another issue with the heart that can put mom and baby both at risk. Okay, mitral valve prolapse. This is really actually quite common. You know, they'll have palpitations and dyspnea. They'll go for whatever stress test or EKG they'll get, and everything will look fine, and it's just something they'll have to tolerate during labor, okay? But never let mitral valve prolapse, a woman who's been tolerating it just fine, she has her complaints, you check her out, she's fine. Don't ever feel comfortable. I mean, every time she complains, we really need to check her to make sure, indeed, this is not now progressing, okay? Peripartum cardiomyopathy. This usually presents itself either in labor or postpartum, later in pregnancy or postpartum. This is crazy deadly. I had a girlfriend who had this, and thank God she was a nurse, because she knew that what she was feeling was bizarre, and she went to the hospital, and she had peripartum cardiomyopathy, and when she arrived to the hospital, her oxygen saturations were 60. Okay. So anyways, there's a very high maternal mortality rate with, it's, thank God, very rare. Women at risk for this, okay, so increased maternal age, 4 or more live births, or African descent. This was my friend's first pregnancy. She was Canadian, which is probably why she developed it, because Canadians are crazy. But anyways, no, I say that joking. But anyways, it was her first pregnancy, and she was, no, she wasn't, she might have been 30, 32, somewhere around there. So, you know, she was pregnancy-wise, she was getting close to advanced maternal age. But anyways, she didn't really fall into the high-risk category.
So really, what causes it?
I don't know. Don't know. They don't know. Not really. Okay.
What do you treat it? Just heavy oxygen or do blood?
Yeah. Just support. Okay. And then they strongly discourage ever being pregnant again. That was her only child. Okay. So, I mean, she did have a very traumatic labor and then had a very stat emergency C-section, like 30 hours later. But otherwise, she had no risk factors. Okay. All right. Okay, Eisenmenger's syndrome. So they have a cardiac lesion of some sort. So they end up with a pulmonary hypertension, you know, pulmonary congestion, and mortality rate is also very high with this. Morphan syndrome, the connective tissue disorder, you know, these are really significant for a pregnancy for a mom. Okay, so support basically through the pregnancy. So early diagnosis, so hopefully they know about this before pregnancy and they've been having some sort of treatment. And we'll continue that throughout pregnancy. Depending on if she is on medications, we'll have to determine whether or not that's safe for the pregnancy. So anyways, she'll have her echo, chest x-ray, and all those kind of things. You know, we'll be giving prenatal vitamins and vitamin supplements. A lot of times during labor, we'll put these people on an antibiotic just because, especially gals with mitral valve prolapses. It's just depend on what the physician is comfortable with doing, okay? If we do an antibiotic treatment for mom during labor or with her C-section, it's for mom. It really has nothing to do with baby, like GBS does, okay? So it's basically up to your physician if you're going to do antibiotics or not, okay? Now, depending on, there's a lot of women who have a clotting disorder and don't have heart disease, but one of the things we may do with a woman that has a heart problem is put her on a heparin drip during labor, okay? But depending on the severity of her heart disease and how she's doing in the labor process, we may have to give her some rescue meds, okay?
I would think heparin would be kind of contradicting the whole make her stop bleeding.
What's that?
It's
right, so it's a fine line. So, right, heparin is going to cause you to be at increased risk for bleeding. And then when a woman delivers a baby and we're already worried about postpartum hemorrhage to begin with, that's an issue. However, are you going to sit there and let her clot?
Yeah.
Okay? So it is a fine line. They have a strict protocol for running that heparin. And, you know, we do have some medications that can help us in the event of a postpartum hemorrhage. So, and pregnancy is a hypercoagulable state anyway, okay? So now you got a woman with heart disease and or you might have a woman with a clotting disorder on top of that. So we have a handful of gals we run heparin on, okay? All right, any questions about heart disease? ABCs, okay? ABCs. Wait, how?
Last chapter,
No. No. Oh man.
growing. So
I don't know how to fix this. Can you guys see that? Should I turn off lights? I don't know how to fix that.
Can you click on that thing next to the magnifying glass? Yeah, to the right.
Oh, you killed it.
Sorry.
Yeah, I'm afraid to click on stuff because, what's that? No. I don't know, but you guys, can you guys?
display settings at the top.
You obviously need to just start clicking.
I don't know, sorry guys, I'm very computer illiterate, so,
Oh, up there you've got 2. Yeah, see.
anyways, you can see that. Okay. Okay, now we're going to talk about gestational problems. So when the first batch of slides, those were pre-gestational problems. So those were problems that were probably evident before pregnancy, except for the gestational diabetes one. But pre-gestational means she had the problem before pregnancy, and these are gestational problems, so they are problems that developed because of the pregnancy, okay? Or they developed in pregnancy. Now this is probably going to be a little bit of a review for you guys, but abortion, remember, is a pregnancy loss before 20 weeks, okay? And they can be elective abortions, okay? But whether they're elective or spontaneous, the medical world calls them abortions. The family calls them miscarriages. So when you're saying to your patient, oh, I see you had 3 abortions, she's going to, yeah, no, I did not, thank you very much. So be careful throwing that word around in front of your patient. But spontaneous, okay, so yes, it occurs spontaneously. It's induced, okay, or elective. It could be induced because of patient election or because of a severe maternal indication. So if they're spontaneous, we call them miscarriages, or the patient calls them miscarriages. And so here's several reasons why there could be a spontaneous abortion. Is chromosomal anomalies. This baby is not growing right and then ends up dying in utero. Teratogenic drugs, exposures, environmental, work hazards. They don't have to just be bad drugs and moms getting on the street, okay? It could be some naturopathic herb, tea, okay? So those all fall in that category. Faulty implantation, weak cervix, incompetent cervix, placental anomalies. So you can read through those. Hot tub or jacuzzi may increase her. Why do you think?
It increases the body temperature.
The heat, yeah, the heat, okay? Now, hot tub, okay? So you've got a woman, well, there's no shower in my house. I've tub bathed for years. Okay, yeah, you can tub bath. You don't want it hot, and don't submerge yourself in this very full tub, okay? So usually in jacuzzis, you're sitting in there, that belly is submerged in that hot temperature. And people sit in there, okay? They don't just wash and get out, okay? So they can still do their tub baths, okay? Just not so hot, and don't fill the tub up. You're not swimming, so just wash and get out, right? Okay? Are people laughing at when I'm washing?
How my Gramps says it.
My mom says it too.
All right. So she's going to have an abortion, a miscarriage, and then they divide all that stuff out, okay? How many things do we have in the medical ward or a medical world, and then you find out there's like 4 degrees of it, okay, or 5 degrees. Well, there is an abortion, so there's a threatened abortion. So threatened abortion does not mean she's going to abort. That means she's having all the signs and symptoms of aborting. She's having contractions, maybe bleeding. She has a fever, whatever, okay? We can try to support her somehow, decrease the fever. Maybe she has an infection, give her some antibiotics, put her on bed rest, okay? But if she's going to have this baby before 20 weeks, there's nothing we can do for the baby. And there's really nothing we can do, really, to stop her from doing that. We can just try to support, try to put her on bed rest, try, okay? Imminent or inevitable, yeah, she is definitely going to lose this pregnancy. A complete abortion means that she has aborted and everything has come out. Everything related to the pregnancy has come out, okay? That's a complete abortion, as opposed to the incomplete abortion where she retains some products. If she retains some products, what is she going to do? What is a mom going to do if she still has, she's going to bleed, okay? And she may get infected, okay? A missed abortion just means that the fetus has died and she has not aborted it, okay? So we may need to help that process, okay? Because if that can't stay in there forever, okay? That does need to come out. She's at risk of bleeding, infection, and DIC. Okay, does everybody know what DIC is? Disseminated intravascular coagulation. Anybody who has a severe hemorrhage or bleeding can be at risk for DIC. It's not just a pregnancy-related thing. However, pregnant women are at increased risk for this because of their potential to bleed. A DIC is a life-threatening, multi-system, multi-body clotting cascade and bleeding. So they're clotting and bleeding all at the same time. Okay. Anyways, she's at risk for that. Okay.
Why would you wait 6 weeks? I mean, why would you leave them there for 6 weeks?
Yeah, why would you? Okay, so a physician, why would he? Okay, I don't know. And they do. And but yeah, I mean, just bring her in, give her some Cytotec or whatever.
So if you have dead tissue, aren't you going to become sepsis before 6 weeks?
You may not, because hopefully if that has died, you know, it will expel. And who knows when, depending on mom's susceptibilities, mom's internal fighting mechanisms, when she will develop infection. So why would you wait? You know, why would you risk it? So, so yeah, so if it's retained beyond 6 weeks, okay, so yeah, I don't know that anybody would wait 6 weeks for this woman to crash before they went in and did something, but this is just saying.
Does mom's body return to pre-pregnancy, or does it still recognize it as pregnant?
She won't recognize it as pregnant anymore, no. All right, so this is just showing you that in a threatened abortion, okay, so she may not abort, but she's bleeding, and that's probably the first thing you're going to hear about from the woman is bleeding, okay? And, you know, some women will bleed a little bit all through pregnancy, but we do have to address it. And yes, please advance to the next slide. Here's an imminent, and she is bleeding just like the previous one, but in the previous one, if you can see from this picture, it appears that the placenta is completely adhered to the uterus, okay? It's not broken away. So maybe just a little edge has lifted, okay? But in the imminent, the placenta has broken away from the uterus, okay? She is going to lose this pregnancy. Bed rest, hydration, nothing is going to make that better. Now here's your incomplete. So she passed the baby, and she retains the whole placenta, or even just parts of the placenta. And so she'll just bleed and get infected, and so yeah, they go in and they take that, okay? Here's some other categories of abortion. So recurrent or habitual. They've changed the name from habitual to recurrent, because habitual makes it sound like this woman has a terrible habit of having an abortion, okay? So that's why they've kind of changed to be a little more politically correct. But this is 3 or more consecutive losses, okay? And then as the septic abortion, this is when she's retained products, and she gets, this is when the she's going to have an abortion. Her water is broke, but she doesn't. She doesn't cramp. Maybe she bleeds a little bit. Maybe she doesn't bleed at all. But we don't know. We don't know this is going on. So she can get septic, okay? Or the pregnancy can get septic, okay? Just like a chorioamnionitis. Okay, so anyways. So we'll do a spec exam, we'll do an ultrasound, we'll do lab studies, we'll check mom's H&H because she's bleeding, right? We'll put her on bed rest, no coitus. Okay, Sheldon wrote this slide. And you know, we do what we can to try to support her and hope that this pregnancy settles down and continues on. Now, if she's having bleeding and she's aborting, why would we give Rogam? Who cares now?
For the next one.
For the next pregnancy. We don't know what that RH is on that aborted fetus, okay? So it could, mom could be RH negative. This would be for an RH negative mom, okay? I'm sorry. We wouldn't give Rogam if this was an RH positive mom, okay? This is an RH negative mom. We don't know what that fetus was, so we go ahead and give mom Rogam, okay? So this is saying that if she doesn't pass all the pregnancy within 4 to 6 weeks, she'll be hospitalized. We'll do a DNC. We may have to induce, like do an induction to get her to pass this. So you know, you don't, you know, this abortion could have happened at 19 weeks. Okay, I've done a lot of inductions on 19 weeks, and that's a fully formed baby. Now, you can't tell a baby has skin, it's so thin, it looks just bright red, very tiny, the eyes aren't open. Some of my moms have wanted to hold this baby. So it can get quite emotional for everybody involved in this process, even the healthcare people, okay? All right, so if she has bleeding, the first thing we're going to suspect is, you know, she might be having an abortion. But here's some other reasons why a woman might have bleeding during pregnancy. She could have an ectopic pregnancy, trophoblastic disease, a placenta previa, or an abruptio placenta, okay? So we'll talk about those. Ectopic pregnancy is a pregnancy that is fertilized in the fallopian tubes. Well, all pregnancies are fertilized in the fallopian tubes, but that fertilized egg doesn't get out for whatever reason, okay? And it usually, the pregnancy, the pregnancy goes on like they don't know anything's wrong, okay? And that egg will attach to the fallopian tube just like it would have if it made it to the uterus, and it will start growing, okay? And if these aren't evacuated, then that growing egg is going to burst that tube, okay? This woman's going to have severe pain, she's going to have bleeding, and have a big problem. But that egg could implant somewhere else, okay? It's an ectopic if it implants anywhere besides the uterus, okay? Do you see these black dots? These are all areas in where that egg can implant. Do you see the intestine there? Okay, so these are pretty rare. I mean, there's a defect somewhere where it gets out of the tube. There's a defect in the uterine wall. It penetrates the uterine wall. You know, a bladder. But those are really super rare. They 99.9% of the time they occur in the fallopian tube. Okay. All right, so she has all the normal signs of pregnancy, and the pregnancy continues as normal, okay? The baby grows, the fertilized egg grows, okay? If we don't evacuate it, then the tubes rupture, and she starts bleeding. All right, so when that egg implants into the tube and starts growing, okay, it's not going to like all of a sudden grow overnight and burst her tube, okay, so it's a slow process. She'll start feeling pain, okay, and you know, we will do our abdominal palpation, and we will detect, from our palpation, she will have that rebound tenderness over a fallopian tube, whichever side, okay? And then we can do some lab tests to kind of help us determine. We'll do our menstrual history, we'll do a pelvic exam, we'll do a vaginal ultrasound, and we will probably see this ectopic pregnancy, okay? And then we will go in and get it. We don't like induce labor like if this was a normal pregnancy in the uterus. We go in and get it. And hopefully we've gone in time to just get that fertilized implantation out of there and save the tube, okay? Or we may need to do a salpingectomy and take the tube, okay? The methotrexate, we can give that medication. So if you remember from PN class, so when the egg is fertilized and it differentiates into the trophoblast and the blastomere, blastocyst, the trophoblast is the thing that develops into the placenta and the chorion, okay? So what this drug does is it interferes with that development, and it's not able to continue to keep attaching and growing, okay? So then hopefully it'll pass. But the majority of the time it's beyond that stage. It's too late for that drug, okay? And we end up having to do the
Can you do an elective abortion with that?
well, yeah, I mean, that would,
Is that essentially what the methotrexate would do?
yeah, it would, yes, it would keep it from continuing to implant and grow, okay? So it would pass or be absorbed, whichever way, okay? But usually by the time we've caught this, it's too late for that drug to work well, okay? So we usually end up going in and getting it, okay? All right, and then hopefully we can save her tube, okay? All right, gestational trophoblastic disease, okay? This is another problem, or this is a problem with the trophoblast differentiating and proliferating correctly, okay? There's a few different forms, as there is with everything. There's the most common mole, hydatiform mole. There's the invasive mole, and there's the choriocarcinoma. Now, with the, oh, please tell, I hope yes, I'm sure I did, show you a picture of this. So with the hydatiform mole, and it's very commonly called molar pregnancy, is what you might always hear, okay? So this egg is fertilized, okay? The placenta, the trophoblast starts developing into the placenta, okay? But then that development changes into a big cluster of grapes, is what it, blood-filled sacs, okay? There's the complete and partial. The complete is the ovum has been fertilized, but there's absolutely no genetic material in the ovum, okay? No genetic material in the ovum. The sperm is just fine, the ovum is not, and this is a hydatiform mole. This is the molar pregnancy. They're just big clusters of blood-filled globules, okay? Now, in a partial pregnancy, the egg is normal, but the sperm is not, okay? The sperm comes complete with 46 chromosomes. And if you remember from meiosis and development and all that kind of stuff, the ovum has 23, the sperm has 23, and then they fertilize and now they have 46, okay? But with the partial mole, the ovum has the normal 23, now the sperm has 46. So you add that together and now you have 69 chromosomes, and that's not cool, okay? This is our second type, the invasive mole. It's very similar to the molar pregnancy, except this grows into the uterine myometrium, okay? Now this woman will have, may have some bleeding. That does grow, so she will have, you know, she will, her uterus will be growing as well, okay? She may say, you know, I passed this big glob of grapes. But then when you put the Doppler on, there's no fetal heart tones, okay? So we see this with ultrasound, and then we just have to go in and get that, okay? A DNC or curettage, okay? Now, the same with the abortion. If this is an Rh negative mom, we will go ahead and give her Rogam just in case, okay? Now, if she has the third type, choriocarcinoma, then she will probably get hysterectomy. Now, so she had the molar pregnancy. We went in and we've gotten it, okay? She's at huge risk for developing a malignant basically choriocarcinoma, a malignant tumor, okay? And so she needs a lot of follow-ups, okay? This does not mean she will develop this malignancy. It just means she's at increased risk for developing a malignancy, okay? They're not very common, thankfully. Any questions about those? All right, hyperemesis gravidarum is basically nausea and vomiting during pregnancy. Why is that different than morning sickness? Because it's way more severe and a little more uncontrolled, okay? And can continue throughout the whole pregnancy. Of course, some morning sickness does, but hyperemesis gravidarum is a very intense version of morning sickness. So much so that this woman can be severely dehydrated. She could be hypovolemic, have hypotension and tachycardia. Okay, it can be really bad. It's so severe that it can start developing or start impairing renal function. Okay, she can start having. I mean, basically, this is a starvation type of condition. Okay. They literally cannot put anything in their mouth. And that even if they do not put anything in their mouth, they are constantly dry heaving. Okay? It's just, it's really intense. These patients can be admitted to the hospital. Okay? So we'll do everything we can to stop the vomiting, correct the dehydration, restore electrolyte balance, and maintain nutrition. Now, if you have a woman, I mean, you can give her Zofran or something like that, or you know, Pepsid or Reglan or whatever, and you can control her vomiting that day, and maybe she's able to eat that day. But this is not treatment as in we fixed the problem and now it's going to go away. Okay? This is a continual problem for these patients. So of course we'll give her IV fluids. We may give her electrolytes. We may give, you know, nausea medication. If this is severe enough, you know, if we can give her nausea medicine, put her on PO nausea medicine, send her home, and she's able to eat and live on nausea medicine, then great. But more often than not, that's not the case. They'll just vomit up the nausea medicine, and they end up on TPN. They end up with PICC lines and on TPN, and usually it's throughout their whole pregnancy. Now, we have had quite a few patients on TPN here in this community, and we can send them home on TPN, and then they just get you know, they get a health nurse. They get a home care nurse that comes and checks on them on regular intervals. She may not ever eat anything else. It's pretty bad. It's pretty bad stuff. Okay. Hyperemesis gravidarum, very different than your typical morning sickness. Okay. Now fun stuff. Hypertensive disorders in pregnancy. So preeclampsia, eclampsia is one of them. Chronic hypertension, so that was a pre-gestational problem, right? That she brought with her to pregnancy. You can have chronic hypertension, and then she can develop preeclampsia on top of that. And then she can just have gestational hypertension, okay? And all these are very different. Now, hypertension in pregnancy is not, unless it's chronic hypertension, is not really related to the factors that you guys may be familiar with in a patient with chronic hypertension, okay? Because of pregnancy and this developing preeclampsia, let's go back. Let me go back before we start here. So preeclampsia, I'm sorry, I want to make sure I define these, and I don't know that I did in the slides. Okay, yeah, I did. Okay. All right. So a person who is preeclamptic has a resistance to angiotensin II, okay? Or a loss of resistance to angiotensin II, okay? So they have a decrease in the prostacyclin and nitric acid effects, vasodilators and platelet aggregation inhibitors, okay? So they have a decrease in those products, so they do not vasodilate well, okay? And then this thromboxane is a vasoconstrictor, and so thromboxane runs wild in her system. So now that she does not want to have the vasodilator prostacyclin, okay, so her body does not want to vasodilate. Now her body wants to boost up this thromboxane, which is a vasoconstrictor, okay? Now, so she has no vasodilating going on, and she's vasoconstricting, okay? Now, what's that going to do? So that's going to decrease renal perfusion, okay? And the glomerular filtration rate, okay? So we are going to see a decreased urine output and a retention of sodium, okay? So she's got a decreased urine output, she's retaining sodium, so she's going to extravasate, okay? She's going to dump all her fluid in her extracellular spaces, okay? So that's where you see the edema in preeclampsia. However, edema is not diagnostic of preeclampsia, okay? So I'll just throw that in there. All right, so also within the kidneys is she's going to start retaining creatinine, BUN, and uric acid, okay? So her serum levels of creatinine, BUN, and uric acid are going to be increased. And then she's going to be spilling albumin, okay? Albumin is a large molecule, okay? And with all this, with the kidney being backed up, this large molecule actually gets pushed out, okay? And then she has a low albumin, serum albumin level. And then, you know, all these things contribute to her extracellular tissue volume, okay, and increased edema. Now, if it's affecting the kidney this way, can you imagine what it's doing to the placenta? Okay, so the placenta is, so she's vasoconstricting, okay, and so the placenta is vasoconstricting, so there's not a lot of good gas and nutrient exchange through the placenta, therefore baby ain't getting nothing, okay? So we're going to see problems with our baby. All right? Okay, so do you see how preeclampsia is different than regular hypertension? Okay, so and the reason why I tell you that is if there's a question on an exam, or if you're doing a care plan, I don't want to see about cardiac dysfunction. I don't want to see about anything that has to do with chronic hypertension, unless your patient has chronic hypertension, okay? All right. So eclampsia has, or preeclampsia, I'm sorry, they have a few different levels, of course, like everything does. Mild and severe. Okay, preeclampsia, mild and severe preeclampsia. If they have mild preeclampsia, their blood pressure is typically somewhere above 140/90. If you have a patient on a couple of blood pressure checks over a 6-hour period, they measure greater than 140/90, then you're going to probably order a 24-hour urine protein exam, lab test. So she will have to go to the lab and get a big brown bucket and take it home and collect all of her urine for 24 hours. And she'll take it back into the lab, and if she has more than 600 milligrams of protein in her urine, then that is diagnostic. Her blood pressure and proteinuria are diagnostic for preeclampsia. Now she will have a weight gain because she will have edema. Again, that is not diagnostic. It could be a screening heads up for you, but it is not diagnostic. Now, severe preeclampsia is their blood pressures are hanging out greater than 160/110. And they're spilling 5 grams of protein in their urine on your 24-hour urine deal, okay? And then you will start seeing oliguria on these people. So when she collects her 24-hour urine, she will have less than 500 cc's in that 24 hours.
So all 3 of those things have to be present?
It's just the blood pressure and the proteinuria
Okay.
are diagnostic, okay? But you'll see this, and you'll see edema, and you'll see weight gain, but those are not diagnostic, okay? You'll see a decreased urine output because you saw what it does, what having preeclampsia does to your kidney, okay? All right, so she may come in reporting these signs and symptoms, visual disturbances. So, part of our questionnaire in the hospital is, do you have any problems with your visions? Are you seeing halos or spots in your visual field? Okay. Any problems breathing? Any pain in your, up here on the right side of your belly that is not related to contraction pain, or that does not feel like contraction pain? Okay. Of course, she's not going to tell you she has impaired liver function, but so we will start doing lab tests. We will, we'll do a CBC. We will do a metabolic panel. We'll do a urine. We will do liver function studies. Okay. We will put her on the monitor and we will check her baby, because all this is happening to the liver and kidney, it's happening to the placenta, so we have a compromised baby. And then HELP syndrome is related to preeclampsia. This is where she is sick enough that she starts hemolyzing, her liver enzymes are elevated, and she will have a low platelet count. HELP syndrome is the mnemonic for those conditions, okay? So if her severe preeclampsia is severe enough, she will start having HELP syndrome. These women, when you're doing your assessment on them, they will have hyporeflexia and clonus. So when I test for hyporeflexia, I'm testing her I'm testing it in her knee, okay? +1 or +2 are normal. +3 or +4 are hyperreflexia. And that is, you kind of get used to what looks normal, and then anything else is a +3 or +4. If she's a +4, then you bump into the bed and she jerks. Okay, it's pucker time. If she has clonus, so you dorsiflex the foot And when you dorsiflex the foot, it'll go like that. And not everybody's here. So you dorsiflex the foot, and the foot will vibrate. Okay, that's the best way I can say it for the hybrid people. It'll vibrate, and you count how many times it does that. So you'll say, my patient is hyperreflexic with 3 beats of clonus, or 2 beats of clonus. Okay? Why is that important? Because this is now affecting her CNS, and she is at huge risk for what?
Cardiac.
She's at huge risk for eclampsia, which is the patient will now have seizures. Okay, so you may have this woman, she's been mildly preeclamptic all through her pregnancy. During labor, she's only having blood pressures of 140/90. Everything's going well. She delivers her baby. Okay, everything's going well. You transfer her to postpartum. Everything's going well for a couple hours. The nurse goes in to check her, and she's laying in the bed seizing. This can occur postpartum. Even the hallmark treatment for eclampsia is delivery of the placenta, but it takes a while for all the pregnancy hormones and chemicals and stuff to leave the mom's body, and for whatever reason she's being preeclamptic. We know what she does when she gets preeclamptic. We don't know why she does it. She can continue that postpartum for 24 hours or 48 hours. So anyways, so when we have a gal who comes into labor with preeclampsia, she's started on mag sulfate. Mag sulfate is a CNS depressant. It is not an antihypertensive. A side effect of mag sulfate is hypotension. So a lot of times when we're running mag sulfate on a woman whose blood pressure has been consistently over 140/90, we bring them down to 135/86. Okay, so the patient feels like, oh, this is what you're doing to treat my high blood pressure. No, this is what we're doing to keep you from seizing. Okay? And this is what we're going to run on you 24 hours after you deliver your baby so we can keep you from seizing.
So do you have this patient on antihypertensives throughout the?
Sometimes they do and sometimes they do not.
Really?
Yeah. Okay. If they're in mild preeclampsia, the physician may not start them on antihypertensives just because it's mild, and they don't want to drop them to a blood pressure that now makes them hypotensive. That could be a problem as well. Okay. But if she has severe preeclampsia, she may be on an antihypertensive.
And then the mag sulfate goes on once labor starts.
When she's admitted for labor, yes, it goes on. And it continues for 24 hours after delivery. Now, I said mag sulfate is a CNS depressant. It crosses the placenta. So who else is getting mag? The baby. So if you're receiving the baby, if you're the baby nurse, you need to be aware of that because your baby may be a little depressed. Okay, not want to breathe and do all those kind of things. Okay. All right. I thought I had the definition slide. So, you know, we talked about mild preeclampsia and what that was, so you all are experts there. We talked about severe preeclampsia. You all are experts there. We talked about eclampsia. But there's chronic hypertension. Okay, chronic hypertension is hypertension she had before pregnancy, right? Okay, so how can she get preeclampsia on top of hypertension? Well, the diagnosis for preeclampsia is proteinuria and high blood pressures. We already know she has high blood pressure, so is she going to start spilling protein? And preeclampsia is diagnosed after 20 weeks. Okay, So it's not diagnosed before 20 weeks. So that's one of your keys there, okay? So what is gestational hypertension? Gestational means she developed hypertension in pregnancy, so why is it not preeclampsia? Why would we just...
She might not be spilling.
She might not be spilling urine. Yeah, typically you can diagnose this before 20 weeks, and you know you may diagnose this after 20 weeks, but she's not spilling protein. Okay. Okay. So we test mom. We do a lot of prenatal labs, you know, in the first visit or two of when she first becomes pregnant at the clinic. Okay. Toxoplasmosis. So if she has a risk for this, we will just educate her. Toxoplasmosis. You know, eating raw meats, but the big one is the cat feces. So if you talk to your patient, you're doing your history, your new pregnant patient history, you're going to ask the questions, does she have a cat, and who else is going to change the cat litter? Okay. We test them for rubella. We don't usually test for cytomegalovirus. Herpes simplex, we don't usually, or do they? Yes, they do test for that. They test, they test for the herpes simplex virus. The group B strep is the one that you've heard me say we don't test until about 36 weeks. Because women can walk around with group B strep and not have any problems. It would be considered maybe a norma flora, okay? But we want to know what her status is before she labors, because babies can contract this group B strep and become very, very septic and sick. Okay? So if we test her at 36 weeks and she's positive and she goes into labor whenever, she will be started on antibiotics during labor. We are not trying to treat mom and eradicate her group B strep bacteria. We're trying to prevent baby from contracting a group B strep infection. Okay. Okay. So let's see what happens to baby if mom has toxoplasmosis infection. So baby can have some type of encephalopathy. Okay, fetal growth restriction. Baby can, mainly brain stuff, convulsions, coma. Okay. So we give mom spiromycin and we can also treat baby as well. However, if baby has had a lot of compromise in utero, this might clear the infection for baby, but then you've got all this other stuff to deal with for baby, okay? All right, rubella. Fetal risk for mom who is non-immune. And we hope to vaccinate prior to pregnancy. However, we do not vaccinate during pregnancy. And we vaccinate after pregnancy.
So my patient that I was looking after, she delivered and then they put an order in for needing a rubella vaccine. So that was either she had a low titer, right?
So
or
they
she
can
wasn't
be,
vaccinated.
right. So when they test for rubella, they're either immune, non-immune, or equivocal. So equivocal means they can't definitely rule her out as immune. Okay. So I think your patient was equivocal, was she, Galen? So if they're non-immune or equivocal, then they will be vaccinated. Both of those, non-immune and equivocal, will be vaccinated. Okay. Okay, cytomegalovirus, it does cross the placenta, causes mental retardation, hearing loss. It causes a lot of encephalopathy type of problems, or it causes nothing at all. And there's no treatment except for taking care of baby post-delivery. Herpes, these are your baby risks. Your baby can be infected, and we do treat baby with acyclovir if indeed baby is infected. However, we treat mom, I think about starting 36 weeks, they put mom on acyclovir, and we do that to prevent an outbreak for when she's in labor, so that she can possibly deliver vaginally. Okay, if she does have an outbreak, she will need to deliver via C-section. Okay, GBS we did speak about quickly before. We screen about 36 weeks. Mom gets penicillin usually during labor, okay, to treat baby, to keep baby from being infected. HPV normally doesn't go well at all for baby if she has HPV virus. Okay. Any questions about those things? I'm pretty sure have we talked to death about RH, or is it just my PMs? We have? No? Do we want to review real quick? We've got 6 minutes. Okay. RH is a blood group, so they have their ABO blood group, and then they have their RH blood group. They're either RH positive or RH negative. So what happens basically with RH negative people is if they get RH positive blood, then their body starts to mount a defense against the RH positive blood. Okay? Now, if a woman is pregnant and she is RH negative and her first pregnancy is RH positive, she will mount a defense, but that defense doesn't affect that pregnancy. That defense affects the next pregnancy, okay? Because she has to be exposed to that RH, and that usually occurs during labor, or if she was to have an abortion, or if there's some sort of bleeding problem in the pregnancy, she could be exposed to that RH positive blood, okay? So when she delivers, then she probably has had an exposure to that RH positive blood, and she is going to mount a defense. Now, when she gets pregnant again, then that defense will cross the placenta and then start attacking the fetus, okay? So it attacks the fetal red blood cells. These babies can, this can cause spontaneous abortion. Or if baby does end up making it to pregnancy, baby can have a lot of issues, and we'll kind of hit those here real quick. So this is what it can cause for babies, okay? So that defense mechanism that mom developed will attack the second pregnancy and cause a severe fetal anemia, which they term as hydrops fetalis, okay? It can cause a severe jaundice, and that's because it's a breakdown of red blood cells, which is the pathophysiology for jaundice, okay? That jaundice can be so severe that we now cause irreparable brain damage. Okay? All right, so we do an antibody screen on mom to determine if mom has been sensitized. We do this prenatally, and then we do this again after delivery, okay? This measures the number of antibodies if she has been sensitized, okay? If she has not been sensitized, then they rescreen again at 28 weeks, and if still negative, then she will get her RhoGAM injection at 28 weeks. And then we do this again after delivery, okay? She's screened again after delivery. Now, if she is sensitized, that means she has a positive antibody screen, then the lab will have to determine what kind of antibody that is. It may be completely unrelated to this issue, but if it's related to this issue, we might not be able to give her RhoGAM. Okay, so basically the lab kind of tells us what to do at that point.
If she's had RhoGAM 28 weeks, isn't she going to screen positive for being
So by the
sensitized?
time she delivers at 40 weeks, her antibody screen may show levels of antibody titer from the previous RhoGAM, and then that's why they do the count. And then lab will tell us, yes, she does have, I think it's antibody D is what they call that when she still has RhoGAM on board from the 28 weeks. Then the lab will tell us, but she's okay to screen. I mean, she's okay to give the RhoGAM. Okay.
It depends on how high the antibody
Right.
count is.
Okay, but if it's high enough, you know, I don't know what they use to determine what is good and what is not good. But then we just kind of monitor this pregnancy very, very closely. Okay. Okay. So this is the name of the test that they do, the indirect Coombs test, okay, on mom. So, so once the baby is born, well, even before the baby's born, so we're doing the close monitoring. If we have a bad baby, we can do intrauterine blood transfusion. I've never done that. Okay, but anyways, we will end up delivering this baby, and then we're dealing with baby afterwards. Okay, so after pregnancy, you know, if the lab work is okay, we will give mom another RhoGAM injection. Okay. Questions?
When they do the intrauterine, it's through the umbilical cord.
Right. So in utero. So, you know, similar to the amniocentesis process, they stick a needle right in there. So test on the 13th, is that correct? Does everybody agree with that? Is anybody going to be here on the 15th?
No.
Okay. Good, I'm not going to be here either. I will record your lecture.
I like how thorough you are about
Oh, I have a question. When is our ATI?
Have it done. Yeah, I didn't put for your practice ATI test. Just have it done before we go to take the proctor. Is that good?
Which is on the 20th.
HPV? Human papilloma? Oh, HPV. Oh, yes. I'm sorry. Oh, I just totally. Human B19 parvo. Oh, parvo. What is that? Parvovirus. Cats? No, that's the toxoplasmosis.
I think you do.
Parvo.
It has to go to the registrars and then you have to go to the.
Yeah, we'll have to,
I heard you say HPV and I was like, that's not
yeah, that's not That's HPV.
Also, what's this?
We'll look it up.
Increase amniotic fluid.
Yeah. So hydramnios is too much fluid. Oligo is too little. And they used to just call this polyhydramnios. But now they just call it hydramnios. Okay, too much fluid.
Yeah, I don't know what this is, but it's bad.
Oh yeah, it's bad. I mean, there's no questions on the exam for that, but yeah, I just, there I go. I just looked at it and assumed what I thought I assumed, so that's not good.
We don't have any evidence, so it's just a test.
Yeah, which I need to do 12 of.